All right. All right. Thanks for coming. It's our MedEd Grand Rounds. We have Dr. George C. Hill with us. He's a Distinguished Professor Emeritus of Pathology, Microbiology, and Immunology at Vanderbilt University. He is the first Vice Chancellor for Equity, Diversity, and Inclusion and Chief Diversity Officer, also at Vanderbilt University. Dr. Hill obtained his Bachelor of Science degree from Rutgers University. He then went on to get his Master's of Science degree from Howard University and his PhD from NYU. Dr. Hill is a researcher in the field of African trypanosomiasis. His laboratory is the first to grow Trypanosoma rhodesiense in culture, the causative agent of African trypanosomiasis. He has received extensive research support from the NIH, the National Science Foundation, and other federal agencies. Dr. Hill has been a member of the National Academy of Medicine since 1998 and was elected a fellow to both the Academy of Microbiology and the American Association for the Advancement of Science. He also served as a Fulbright Scholar at the University of Nairobi and an NIH Special Research Fellow at the University of Cambridge. Dr. Hill is a Fellow of Health Disparities of the Cobb Institute of the National Medical Association. Dr. Hill has served on numerous governmental advisory committees focusing in on biomedical sciences research and graduate education. He was appointed to the NIH Fogarty International Center Scientific Advisory Board, National Institute of General Medical Sciences Advisory Council, and the National Institute of Allergy and Infectious Diseases Board of Scientific Counselors. Currently, he serves on the CMSRU Medical Board, as well as the Cobb Health Institute Board of Directors of the National Medical Association, as well as the NIH Advisory Committee to the Director Working Group on Diversity. In his career, Dr. Hill has trained numerous graduate students and postdoctorate fellows. He was recognized as a giant in science by Quality Education for Minorities Network for his commitment to motivating minority students to pursue the sciences. He chaired the National Science Foundation Committee for Equal Opportunity in Science and Engineering. He works throughout the country to advance opportunities for underrepresented minority students in medicine and in the biomedical sciences. Dr. Hill was elected by the Student National Medical Association to their Hall of Heroes. In addition, he received the Distinguished Faculty Award from the Organization of Black Graduate and Professional Students of Vanderbilt University. In 2016, Dr. Hill was recognized by CMSRU with an honorary Doctor of Science degree. And in 2017, he received the Distinguished Herbert W. Nichols Award from the AAMC. This award is given annually to an individual who has made outstanding contributions to promoting justice in medical education and health care. As the first Vice Chancellor for Equity, Diversity, and Inclusion, Dr. Hill has been instrumental in working with all institutional constituents at Vanderbilt University to provide leadership in cultivating an academic community that is equitable, inclusive, and diverse. Today, Dr. Hill will be sharing his insights into the role of medical education in achieving health equity and social justice. Please join me in welcoming Dr. Hill to the podium.
Good morning. Good morning. So nice to be here in, where am I, in Camden, New Jersey? All right. First of all, thank you very much for that very warm introduction. Can you hear me? Great. I've actually spoken in this room before, and it's always a pleasure to be here. I come 3 or 4 times a year. I'm very grateful to the Dean for continuing me on the board. I grew up here in Camden, and you'll see that shortly. But it's always a pleasure to come to Camden. It's one of the reasons that I ended up working on and being associated with Cooper's. I remember seeing Dr. Raboli at one of the AAMC meetings, and the medical school was just beginning. And I told her I was from here, and then I met Dr. Mitchell Williams. And it's a good feeling. It's a good feeling to be here. And I really want to compliment you all for the work that you are doing. It's very important, as I will touch on. How do I go backwards? There you go. Great. So this is my family, and I wanted to show it to you before. Okay. Got it. Okay. It's obvious. I have a twin brother, and it's obvious which one of these people I am, so there's no need for me to point it out to you. Some of you who are in the field of OBGYN will recognize that twins look alike, as often was said. We're identical twins. In fact, my mother had 3 children in the same year. How many women how many women have had 3 children in the same calendar year? Please raise your hand. Yeah, right. My mother had the 2 of us in February 19. And then she had my sister in December, who lives over now in Mount Airy, Pennsylvania. My twin brother is a physician. He's an OBGYN. And my sister has retired for about 15 years. She was a reading specialist over in Philadelphia. And she's traveled to all 7 continents. And it's just wonderful. My mother was a domestic worker. She worked in Cherry Hill for about 50 years and did not graduate from college. Did not graduate from high school. We grew up in Morristown. How many of you know where Morristown is? Not Morristown, but Morristown, right? In fact, there was a bio prepared on me once, and this guy who was editing said, I changed the E to I. I figured you had a typo in it. My father was a postman, and he would drive over the Ben Franklin Bridge and visit the United States Post Office in the evening, and he sorted mail by hand. Long before any of you all were born, when there weren't zip codes and stuff, people would take the envelopes and stuff them into a little box, and then they would take the box, and that's what Dad did. He did graduate from Morristown High. Then we moved to Camden. I got to get this right. Okay, we moved to Camden, and this is about 3 blocks from the high school, on a section called Parkside. How many of you have ever heard of Parkside? I've been over near the Fairmount Park, right? So Langham Avenue, and then Empire, and then Magnolia, and then Park Boulevard, right? And this actually is the house today. The house that we grew up in is the one that's boarded up. I went by there yesterday. This is a note that I found that my mother had written and I found it after she passed. And it says, it was written on a sheet of paper. And it said, it's better to become bent from hard work than to be crooked from avoiding it. And I think that's the way she lived. And notice her name is Ruth Esther Clark Hill. This is Women's Month. And I kind of like the idea that she has the name of two individuals from the Bible, Ruth and Esther. Ruth was an incredible woman. She was very faithful, correct? And she stayed with Naomi after her husband died. But when Mom passed, she and Dad had accumulated $90,000 in U.S. savings bonds. $90,000. And I sent my son to Yale for a year with my third. And I still have this one. I don't have any plans on trading it in. So they were very dedicated individuals, and I'm sure very similar to a lot of people who are here who have parents who really committed to make sure that you got to where you are, correct? This is the high school that I went to. This is disgusting. Not the high school, but the fact that it doesn't exist anymore. How many people know where their high school is and it still exists? Raise your hand. Yeah, look at that. I went by yesterday and there was just a hole in the ground and a pile of dirt. It made me cry. In fact, this is a picture of the three of us standing on the steps there. Again, it's obvious which one I am, so I'm not going to point it out to you. And my sister was a majorette. Had a lot of fond memories at Camden High. I should point out something to you. We know which one we are, because my twin brother is about an inch taller than I am. So in every single picture, you can tell which one it is, which is kind of cheating, isn't it? So before I get into real serious things, now you can tell which one I am, right? I'm the handsome one on the right. So I have no conflict of interest, and these are the questions that I'd like to raise today. Is medical education the pathway to achieving health equity and social justice? What are some other pathways for achieving this goal? And what role can medical educators play outside the field of medical education? In other words, those of you who are involved in medical education, what role can you play outside of medical education in achieving health equity? And we'll get to that point. Again, I don't want to forget it. I really appreciate being able to serve on the board. I appreciate being here. It's kind of emotional. I was surprised. I was surprised because I've been. When did the school start?
2012.
Yeah, I've been associated with it for a long time, and I was really honored when I received the first honorary degree. I was sitting next to the governor, and my daughter was out in the audience. In fact, it was right next door, right? Never to be there again, right? Jeez, this is history. And I was sitting there, and my daughter was going, and I realized that she was saying, "Sit up, you're slouching." Jeez. But that was really a beautiful day. It really was. And again, I thank Annette, and I thank Paul, Dr. Katz, who some of you have heard of him, correct? Okay, come on, George. This is your school, our school, and I love the motto. Wherever I go, whether here or abroad, I talk about the motto. Camden is our classroom, Camden is our home. Of course, I grew up here, so to me, that's really significant. It really is. And you're familiar with your commitment to the community and your core values, and they're very, very important. Is this the first class? I got an older slide. Is this the first class? Right. It's a very special class, really. A friend of mine who passed 2 or 3 weeks ago, I was talking with him about one of our graduates who ended up who was the first African American to go to Vanderbilt. His name was Levi Watkins Jr., surgeon. And I asked him what he thought about Levi. He said, well, he was the first. You can't be the first. You can't, being the first is so important because after the first comes a lot of other things. And these young people were in the first class. And I'm sure many of you recognize them, correct? It was noted that I received the Herb Nichols Award, which I'm very grateful for. And the WMC provides a scholarship, recognizes 5 students each year. And in 2015, one of your own was recognized with a Nichols Scholarship, Max Cruz. And I thank Jocelyn for sharing the information with me. He's now a PGY2 at the University of Cincinnati Medical Center, but you can see the commitment that he made when he was here and even before he was here to health equity. And as I said, he was one of the 5 individuals selected in 2015, and it's very competitive. And the students are, if you ever go to a WMC meeting, you should go to the awards ceremony, because there are 5 students from different backgrounds. It's really overwhelming. You really want to cry the efforts that a lot of them have made to get to where they are. So when one thinks of a diverse physician workforce, it's important to point out why it's, some of the reasons on why it's so important, and I've noted them here. Minority physicians strongly are interested in primary care. Some minority patients see concordance as important. I'll talk more about that later. There's a strong interest in minority health research issues and strong model for excellence when you have a diverse class. And Herb Nichols was very active in that initiative. Dr. Nichols was a physician who passed when he was 51, right after he was playing tennis. He was a very slender guy. But he was very active in Project 3000 by 2000. And he was a vice president at the AAMC, and he wrote a paper in the New England Journal of Medicine that proposed, he and Jordan Cohen, proposed, and Petersdorf, proposed that by the year 2000 there would be 3,000 minority students by the year 2000. And you can see the 2 curves. One, the red one, is what the population, and the yellow one is trying to achieve that goal. And by 2000, that was obviously it did not occur. And one of the reasons that it's important that we have it and we work towards it is because by achieving it, we can use tools to attract other students into medicine. And I really have to applaud Jocelyn, Dr. Mitchell-Williams, because she and others of you here have really worked to identify pipeline programs that would help to achieve that 3,000 by 2000. And we haven't achieved it, but we're working towards it. And the type of programs that you have, whether it's in elementary or high school, undergraduate, all are important in affecting that pipeline. Now, I have to tell you something. How many of you are surgeons in here? Being a surgeon is a difficult job, correct? Sir? Can be. It's basically an easy type of thing, like fishing? What kind of surgeon are you? Pardon? Oh, okay. I'm making. What are you, sir? No, you're one that turned around to look to see. Students do that a lot, don't they? Yeah, right? Student, sir, and he looks around you. Me, right? You're a medical student. No, so you're primed to look around and see. What do you want to be when you grow up?
A good doctor.
A good doctor. That's a good answer, really. My point is that, and it's a very important point, working on initiatives and programs to increase diversity in a medical school or in any institution is hard work. It is very, very difficult. And I applaud what Dr. Mitchell-Williams is doing because it's very, very difficult. If you don't think it is, try doing it for 5, 6 years and understand. But being a physician, being a surgeon is difficult as well. But it's really hard work. Never take it for granted. So these are some steps that are important in achieving a diverse medical class. Many of you are familiar with what I have here. The commitment of the medical school leaders is really important and also first. And then even in a university down at Rowan or at Rutgers, where I went to undergraduate, right here in Camden, the commitment of the leadership at the top is really important. And you're fortunate with Dr. Katz and now Dr. Waboli that that is the case. An impactful curriculum. The LCME guidelines play an important role. Recognition of the impact of diversity and a welcoming environment. And of course, a holistic review. Now, there are some challenges. This is a question mark. And I'd like to ask, for those of you, particularly those of you who are looking down at probably something in your hand, what do you see are some of the challenges? So, young man here, what's the challenge?
Called that for a while, that's good. Thank you very much. I think for our school, it's competing with nationally ranked programs for students.
All right, competition. Young lady drinking the hot chocolate. What's the challenge to having a diverse class?
I would say overcoming like the daily critics.
I didn't hear you, I'm sorry.
Overcoming like the daily critics from people.
Correct. You're a medical student, right?
Yes.
Where are you from?
New Jersey.
New Jersey. What part?
The part that calls Morristown, I.
What do you see as a challenge?
I think it's one of the bigger challenges is a welcoming environment.
Welcoming environment, right. So in the interest of time, I listed a few. The pipeline, expense, unconscious and explicit bias, the curricula, both the hidden curriculum and the open curriculum, the racism, testing, and having to do well, and courage. We're going to touch on a few. So testing. This is the new MCAT. And the mean is 500. What was your MCAT when you took yours? You remember?
I don't remember my scores, it was too long ago.
Okay.
Different scores.
Are you a good physician?
I think so, pretty good.
Do you think it had anything to do with your MCAT?
Not at all.
Where are you from?
Philadelphia.
Oh. So the mean MCAT is 500. Okay? Now, this is the new MCAT broken down by race. So 502 is the mean for whites, and you can read the rest. And you can see that it decreases as you go through different racial groups. Now this slide is really important. think I might use the pointer here. Let me see. Where do you see it? Top button, and just hold it? Oh, that's weird. Oh. Thank you. The point that thank you. Hold it. Oh, I had it upside down. That was a problem. That was why it was a problem the whole time. You didn't tell me to hold it. No, not you. I'm messing with you, dude. So you have a 50-50 chance, right? Please look at this. This line, the red line, represents the 500 mean. Okay? And everything to the left is below that mean. And you can immediately see there's some items here that fall to the left. You with me? So, for example, male and female, the mean for female is 499, for male is 502. Now, what is this, you might add? Well, that one is almost totally to the left. You with me? That's the MCAT for Black or African Americans, 493. This one is for Hispanic. What is this? This is the mean, which is 496 for those who received fee assistance. These two are important. This one is parental education, no bachelor's degree versus bachelor's degree. In other words, when you're evaluating the MCAT, you're actually looking at what? The parental education influence on the candidate. Am I right? And this is the parental education. The bachelor degree or higher, the mean is 501. The no bachelor degree is 496. And this slide is very important because it shows the impact of the family income on the MCAT. So this was published again by the AAMC, and these are the old scores. A family of 60K, 78, 100, 110, and 143. What is that showing? Could somebody conclude it for me? You're all bright people. Tell me what it shows.
More money, better score.
How did you figure that out? More money, better score. The other thing it shows is that different racial groups have different levels of scores, even with more money. You see that? But yes, more money, better scores. And then this slide shows something that's really important. It's, again, AAMC data. So it's looking at the parental income of first-year medical students by quintile. And it goes to the point that a gentleman just made. The top 5% in terms of income represents 24% of the medical students. 24% of first-year medical students. That's what you see here. The top 5% there represents 24%. And the lowest quintile represents only 5%. And then there's this thing about using the MCAT to look at residency placements. Have any of you ever been aware of that? So I don't understand something, and that is using the score to determine whether I can go into neurosurgery or pediatrics or other high specialties, basically is using the score for a purpose that it wasn't designed for. But you can see here that there's a direct correlation, and we found that out at our institution, between the Step 1 score and the MCAT score. But again, it's being used for a purpose for which it wasn't designed. So there is something that I want to point out that other schools have done, including our institution. And I think it's really important if one is interested in trying to increase the diversity of an institution. And that is, we realize that for each group, racial ethnicity group, there's a mean score. You've seen that, correct? And the percentile of Vanderbilt at this time was about 79 percentile in terms of the students that we accepted. So 79 percentile would be for white students, the majority of the students that you're sampling, would be about 11.5 or 33, 34 in the old test. But so if one were to say, okay, we're going to look for the mean for all students to achieve that score, because that's the average that we have overall, then for white students, that would be that score, and it would be 77.3. So what would that score be for this score for other groups? Well, you can see that's score 11.5 for other groups. For black students, it would be in the 96th percentile. In other words, if we were selecting students to come to Vanderbilt who met this score overall, for black students, it would be 96.5 percentile. And those students could go at where? Anywhere. Correct? And you can see for Hispanic students, it would be the 91st percentile, and for Asian students, comparable. The point that the institution began to recognize was that if you look at the percentile for your particular group, or you look at the score for your particular group to match the percentile that you're wanting to examine or admit, then it's sliding, but it's the same for the group in terms of the percentile. Does that make sense? Some feedback, does that make sense? And when we did that, we found that the number of students that we were able to attract to the institution who were minority students just started to go up, because the committee recognized that it was important to focus on who was available at that percentile that we were looking for a particular group. Now you might ask, well, how did those students do? Because if they didn't have the mean score for the total, for the majority, were they successful? Well, it's an understatement to point out that they were. They matched at some of the top institutions in the country, from Mass General to Vanderbilt to Penn, wherever. They always did extremely well. And to this day, we continue to do that. So my point is that if one focuses on looking at a particular group, and then what is the mean score for that group that you want, what is the mean score that you would like to achieve? What is the score that you would like to achieve? Then looking at that particular group, any particular group, you'll be able to do that. Because as you saw, if we're just one particular group, then the scores are lower, in which case, if you're focusing on just that score, those students can go anywhere at all. I think it's a very important point, and I think it's a point that more schools are doing. Okay, the second issue that is important deals with the crisis of the black male. And let me go back. All right. Who is this? Ernest. Ernest is now up at Montefiore System. He was one of the first students that I met when I came. But he's a rarity. The U.S. citizens, 1 in 8 is African American, physicians 1 in 15, Hispanic 1 in 6 citizens, and only 1 in 20 are doctors. And the young black male is decreasing in terms of medicine. Only 37.8% of blacks applying to medical school are men. And 13% of the United States population is black, but just 4% of the doctors are black. And this is important, in 1986, over half of black medical school graduates were men, in 1986. But in 2015, there was a drop from 57% to 35%. And one of the things that, a lot of things are being done, and we can talk about the reasons. And there was a meeting that was held by the National Academy of Medicine, as well as the National Medical Association in November to discuss it. And just this past month, there was a meeting held that Mark Neve organized in Dallas, Texas, because it's really important that we reverse the trend. And one of the things that came out of this meeting was that this meeting was held in Texas, but probably in Philadelphia and in New York, there will be other meetings that bring together individuals to discuss the challenge. This is the meeting we had in Nashville, which had the same purpose. But the problem is rather complex. This is a comment going back to the question that was asked, the role of medical education. This is something that Dr. Satcher noted when we were discussing this problem. There's no single pathway, he said, to health equity, but that an integrated pathway is needed along with a team approach. For example, social determinants often require intervention, and that intervention often requires policy change. As a rule, this takes us beyond medical education. And I think Dr. Satcher is absolutely correct. For some of you who do not know, Dr. Satcher was the head of CDC and then the Surgeon General, and now is the professor at Morehouse School of Medicine. He was also president of Meharry. And when you look at the social determinants of health, we know the pie chart, but we also know that the social and economic factors really influence the health of an individual. And you know this probably better than a lot of individuals because you are working here in Camden. You see people from South Jersey who are affected by social and economic factors. And it's to be applauded, the type of efforts that you are making in trying to address. The National Academy of Medicine recommends training for all clinicians to understand and address the social determinants of health. And it points out that this commitment is viewed as a professional responsibility. Training has focused on cultural awareness, and these are some of the things that you do, emphasizing communication, small group sessions, going out into the community, management, diagnosis, and the patient's background are considered very important. So the last 2 points I want to make deal with, first, the one deals with Dr. Cooper. Have any of you ever met Dr. Cooper, Lisa Cooper? You really need to get her here. She would be incredible. She's at Hopkins. She's now a professor in the medical school as well as in the School of Public Health, Lisa Cooper. She received the Nichols Award about 2 years ago, and she's a member of the National Academy of Medicine. And just a really nice person. She's just... she directs the Johns Hopkins Center for Health Equity. And the center provides training to a new generation of health equity scholars and advocates for social change with policymakers. She's written 3 papers, she's very prolific. As I said, she was a MacArthur scholar, and she just takes time to look at ways in which one can achieve equity and really work health equity and work for it continuously. She works for it continuously. And she's written recently in a paper in Public Health Reports and in other journals, ways in which one needs to address the issue. And she points out something that I think is very, very important, which will bring me to my last point. She says there has been a move recently towards structural competency, which posits that clinicians be trained to understand how health inequalities, which you all are trying to address and resolve, are driven by forces at the institutional and societal levels, and to take these factors into account in managing patients. She refers to it as the Ecological Model, an organizing framework for structural competence, which reveals the multiple levels of influence on the health of individual patients. And she's kind of diagrammed it in this way. Of course, here's the patient, and there are multiple influences on health, whether it's the family or the provider and the care team, which the provider and the care team can be affected by the medical education that they receive, the clinical practice setting, the local community and policy and programs, and then national and state government policy and programs. And this is what Dr. Satcher was talking about. Now, the last point, which some of you may not be familiar with, is when it comes to health equity, is a problem sometimes as it relates to the color of law. This is a book that was written by Richard Rothstein. Have any of you ever seen it? The Color of Law. And it's ironic that the evidence for it you can see here in our community I grew up in. So what are we talking about? The housing programs begun under the New Deal were tantamount to a state-sponsored system of segregation, the housing programs by the government. The government's efforts were primarily designed to provide housing to white middle-class, lower middle-class families. African Americans and other people of color were left out of the new suburban communities and pushed instead into urban housing projects. So there were two agencies from the government that played a key role. One was the Public Works Administration, and their responsibilities were housing was primarily designed for whites. Black housing was segregated, purposely separating African American from white neighborhoods. That was the PHA, the Public Works Administration. And the second was the FHA. The FHA, back in the 40s and 50s and 60s, bank loans were not allowed to be provided to blacks. Subsidized building subdivisions in suburbs was one of their purposes. But those suburbs were to be exclusively white. How many of you ever heard of Levittown? Then you know what I'm talking about. No resale to blacks. There were restricted covenants, and subsidized support to whites to move into the suburbs. Now, how many of you know where 130 is, Route 130? Well, you must know where 130 is because you have to cross it, right, or something. Now, on one side of 130 is Camden, am I right? And what's on the other side of 130? Well, let's see, there's Collingswood and Haddonfield. You just keep going down, right? And those were exclusively white communities. And under these policies, of course, Cherry Hill grew up and blossomed. And so where we used to live in Parkside and Fairmount Park, people moved out of those neighborhoods and went where? To the suburbs. And under these restrictions, only a certain group of people could go there. And this is the color of law. And of course, this affects one's health. And an evaluation was actually made by the state. And Richard Rothstein concluded from the studies, we have created a caste system in this country with African Americans kept exploited and geographically separated by racially explicit government policies. So an evaluation was done actually of these policies as it applied to Camden, here. In I-95, you know where that is? I-95 destroyed some 3,000 low-income housing units, and they replaced them with about 100. And then the State Attorney General's office concluded, it is obvious from a glance at the transit plans that an attempt is being made to eliminate the Negro and Puerto Rican concentrations by building highways that benefit white suburbanites, facilitating what? Their movement coming and going back to work. That's the color of the law. So in the book and in other places, they just cite other cities where the exact same thing occurred. Jacksonville, Milwaukee, you see them. How many of you actually now, when you reflect, know or have seen this effect on neighborhoods where you grew up or where you are familiar with? And Lisa Cooper makes the point. Educating and training a diverse group of public health and clinical investigators and practitioners in transdisciplinary methods is important for addressing the health equity crisis. It's particularly important that people from disadvantaged communities cultivate their talents and interests in this work. And that she believes strongly that cross-sector and cross-disciplinary leaders for change in health equity should include professionals with an expertise in the areas that we're talking about, and the background and the experiences that we're talking about. And that they appreciate how what we've talked about affects their health, but also affects social justice. In other words, social justice is not separated from health equity. Would you agree? I don't know who these guys are. You know, when we talk about social justice, we kind of separate sometimes social justice from health. And you probably know, but there might be one or two people who don't know, and there are people in my family who disagree. My daughter's husband, what's he called? My son-in-law? Oh, God, man, jeez. Woo. Oh, we have a really diverse family, I tell you, and diverse in many ways. And he doesn't, what Colin Kaepernick was doing was simply kneeling because of what Lisa was pointing out, social justice. Stephen Clark. Has anyone ever heard of Stephen Clark? Unfortunately, Stephen Clark was an African-American male who was from Sacramento, California, and was shot and killed by the police. Now, if you don't listen to hear, remember anything else I have to say, if you today were to Google police killing and put in a city, police killing black male, and put in a city, something would pop up. Something would pop up. So I did that last night for Philadelphia. And something popped up. The gentleman who was shot in the back, and the policeman is going to go on trial. So, but that says something. If you can just Google your hometown or where you grew up and put in police shooting black male and see what comes up. Just do it. Just do it. Which means we have a problem when it comes to social justice, which obviously is going to end up affecting individuals' health. How old is your son? 20? Your youngest son? 17. Have you and Rick ever sat down with him and talked to him about what happens? I'm sorry, I can't hear you.
Yes, many times.
Many times. Talked about what?
What to do if he gets stopped by police.
And one of the ironic things is that we have to do it. You have children? How many? 3? Yes. Do you have a son?
2 sons and a daughter.
And have you ever had to sit down and chat with your son?
Yes, absolutely.
Right. So my point is that you have to understand, the majority of you here, that social justice is important, and it's linked closely to whether you're Hispanic or African American or minority population, it's part of what you have to do to make sure, recognize it in order to make sure that your son or daughter comes home. Now right. This is a book that, how many of you read this book? What did you think about it in one word? You raised your hand, right?
I guess it was shocking.
You should make a note and consider it. So in conclusion, medical education is part of the pathway to health equity. No question about it. If one were to go to, however, if one were going to go to the Poconos, Nashville, nobody would ever know what I meant when I said if one were to go to the Poconos. First thing you do is get in your car and find a highway and start going in that direction, right? But the third point is the most important, and that is that the successful journey requires many coordinated steps and pathways. And it's the same way with health equity. Yes, medical education plays a very important role, but recognition of the other circumstances that we've talked about, is very important. Where do we go from here? Chaos or community? That could be a whole nother lecture, given a whole nother discussion, given where we are today in our country. Maya Angelou said something which is very important. Courage is the most important of all the virtues, because without courage, you can't practice any other virtue consistently. You can practice any virtue erratically, but nothing consistently without courage. And whether you're a faculty member and you're sitting in a meeting and you hear someone say, I don't care what you say, we're not going to allow anybody in our program unless they have a step one score of 260. And you can do one or two things then. 240. You can do one or two things. You can just kind of nod your head, look down, and grab your phone and look to see. Or you can say, well, wait a minute, why? And you can get into a big discussion, but you can say, why? Of course, the thing I find ironic is that the people who were in the program didn't have a score of 240, 260. If you're a student and your goal is to be here and to get out, right? Yes, sir? Yes. And how long is your program? 4 years? 4 years? 4 years. And how long do you want to take to get out? 4. Well, I understand, but even with getting some additional research, you say, but it's a defined time, right? And so when these type of issues come up, he's interested in finishing. So he might not say, I don't know you, but you might be one who would stand up and say, wait a minute, this curriculum, pardon my French, can we do more in the community? Can we try something different? And you have to have the courage to do it. And finally, with faculty members, we can be bought. I'm sure you don't know that, but we can really be bought. And by that I mean we are committed to certain principles, but if your department chair says, I need you to really lead the program, the residency program, and to really restrict it to 240, 250, and as our new residency director, we got 30% increase in salary and more time to not be in the clinic or whatever it is you want to do comes along with it. And then you might say, well, I don't know. He or she might be right, correct? And so we just have to have the courage to speak up for what we want. Again, I really have enjoyed being here. We have a board meeting in 2 weeks. I was surprised at how emotional it was for me. And I thank you all very much. I appreciate it.
everyday faculty that we have to interact with and the residents and things like that where they might not understand all this and understand the mission. So how do we as students and how does the faculty and deans kind of translate this message to the people that we're interacting with every day?
I think it's a step-by-step process. I think one of the things that really happens is when you inculcate into just the being of the medical school that this is important, and you do it by bringing in individuals who support it, having discussions that support it, making it clear that it's essential. But you do it in every single fabric of the institution, and slowly but surely it begins to work. Now, if you say, well, that might take time and I'm not sure that will work, I will respond sexual harassment. Now, I don't think there's any, or sexual whatever, you know what I'm talking about. I don't think there's anybody in an institution nowadays who knows what's not tolerated, and your job is at risk. So my point is that message has been sent loud and clear by all individuals, including the victims. And I think that infiltration is needed. It's hard. But when I first got to Vanderbilt, the first year was, I served as the dean for diversity in the medical school for a while. It was really, really difficult. It was really antagonistic. My first year, my late wife said she thought I was going to quit. It was just impossible. But slowly but surely, I was able to influence individuals with a wonderful team. But it's very hard work, and you're right, influencing them. And as I said, you just have to have the courage sometimes to if you're over in the hospital, you just have to have the courage to speak up. I was talking with a third-year medical student at our institution. I said, how's it going? He said, well, I understand something, Dr. Hill. When I'm on rounds or I'm over there, people don't look at me. They just don't look. I said, what are you talking about? I said, well, we'll be in a group, and the attending or the chief resident just won't look at me. They'll look at all the other people, but they won't look at me. And I'm sure at one point, not too long ago, the same thing was with women. There'd be 4 men there, and this woman would be standing there, and we just focus on them like I'm invisible. Somebody wrote a book, The Invisible Man. Somebody, I know who wrote it. Yeah, thank you very much. I don't want you to think I didn't know that Richard Wright wrote it. And that's what happens in the settings, right? So, and she said she asked another female student, she was black, and do you notice that? And she said, yeah. So the point is, even in that setting, you have to have the courage, wanting to make sure that what year are you? Fourth year. So how many more do you have? 2? No, you're right. It's a horrendous balance between wanting to say what you feel and let me explain. Let me say something to you. As you get older, you develop the courage. Some people develop it faster than others. But many of us have been in a meeting, I don't do it anymore, but we've been in meetings where we know we should say something and we don't. And it's hard. Sometimes you're the only person in the room. Sometimes you're saying, well, gee, they're going to say, there goes George again, talking about this issue, or and you just have to do it. So that's you have to take that approach. But And I admire you as a student leader to want to do it. The other thing that I think is really true is that the people sitting around the table expect you to say something. I learned that a long time ago. And when you don't, they say, I got him. They really expect you to say something. They do. Good luck to you.
So I don't want to discount the obligation of each individual to be fair and equitable in their interactions with everybody else. And I don't even want to discount the obligation of individual institutions like Vanderbilt or CMSRU to try to rectify the disparities that we know exist. But we've been discriminating on this continent against African Americans for over 400 years.
Mm-hmm.
And it's been systematic, as you point out. And, the example that you gave in that book, The Color of Law. It's time, I think, that we need to advocate for systematic advantaging of the African American population so that the burden doesn't fall on each individual institution, because it's a heavy burden. It is a heavy burden. I mean, there are lots of things that we have to do in order to level the playing field. We need to, as a society, we need to make decisions and set policies that specifically rectify these injustices that have built up, as you point out, that are inherited essentially from one generation to the next. So we need to be advocates. That's really our job.
I could not agree with you more. I think such advocacy is essential. We probably are not going to make the type of changes that are necessary without it. I think that now, at this time, it's highly unlikely that that type of advocacy will occur, but that has absolutely nothing to do with advocating for it. Because you may be the only person in the room pointing out these injustices must be addressed. And you're absolutely correct. In that book by Coates, we were talking about it last night, the first slaves came here in 1609 in Jamestown, Virginia, 1609. And the freeing of the slaves was in 1865. So if you subtract one from the other, you get about 253 or 4 years. If you take 1865 and take it today, you have, 150, you can do the math. So it basically means that our ancestors, or African Americans today, and I don't mean to minimize the impact on other underrepresented minority groups, but African Americans today have been enslaved in this country longer than they've been free. And that's really...
And not really free.
And not really free. Right, and free in quotations, thank you. So that really says a lot about systematic factors, white privilege, and other issues that we have to keep in mind. We just have to continue to address and be realistic about. I remember once seeing Martin Luther King on Meet the Press, and Spivak, the guy who was a reporter at the time, said to him, "Well, Mr. King, I don't understand. Other people have pulled themselves up by their bootstraps, and I don't understand what you're saying. Why can't the Negro do the same?" And I remember the question, I remember his answer. And he said, "Well, Mr. Spivak, it's hard to pull yourself up by your bootstraps when what? You don't have any boots." I'll never forget that. Thank you all so much. Jeez, thank you. Thank you.